Dr. Gidwani, can we start, or are we waiting for some more people to join?
No, I think we should go ahead.
Okay. Good afternoon.
Yeah, we're waiting for you.
Bharat. It gives me great pleasure to introduce Dr. Ankit Bharat. He is the Harold L. and Margaret Method Professor of Surgery and Chief of Thoracic Surgery, and also the Executive Director of the Canning Thoracic Institute at Northwestern University in Chicago. He received his medical training at Christian Medical College in India, with a really reputed college in India, following which he joined WashU in St. Louis. He did his general surgery residency and cardiothoracic surgery fellowship, as well as a postdoc research fellowship there. At Northwestern, he treats patients with advanced thoracic disease, and is also the surgical director of lung transplant and the ECMO program for end-stage lung failure. And his research, he has 3 R01 grants now, and he has tremendous basic science presence and research in the immunopathogenesis of lung disease, with a focus on transplant immunobiology. He also has, his lab is also interested in intravital imaging of immune responses after transplant to determine the mechanisms of recruitment of neutrophils into the lungs. He has several awards, and he has a patent on pleural gas technology. And he's also a founder and inventor of a company called Sidrain. It gives me great pleasure to have you, Dr. Bharat, to talk to us about your experience in lung transplantation, management of severe COVID illness, and your experience in the recent success you had. Dr. Bharat.
Well, thank you for having me. It's nice to see you, Harish. I think the last time we met was many years ago in Texas, and it's great to be introduced by you, and it's my real pleasure to be talking in front of this audience. So I will, let me just share the screen. And what I thought I'll do is share with you all a little bit of our journey during the pandemic. Obviously, most importantly, focused on lung transplant, but I just wanted to share with you how this all came about, sharing with you some of the work we've published, and hopefully highlighting some of the important findings that we have incorporated in our clinical practice. So let me just, you're able to see the slides, right?
Yes.
Okay, great.
Perfectly, yeah.
So this slide is probably redundant. We all know COVID-19 is predominantly a respiratory illness. It definitely can affect other organs, but it's best understood as something that affects the respiratory system the most, and most of the mortality that results from COVID-19 is due to respiratory failure. We also know that 6 to 10% of all patients that get COVID-19 can progress to ARDS and require ventilation. Now, we hope that these numbers are going to come down with the vaccination and the herd immunity and so forth. And we also know that the mortality of patients who develop severe COVID-19 ARDS is upwards of 40% in most series that have been published. And we hope that this may also continue to go down with the advancements in medical therapies and so forth. Now, as the COVID-19 pandemic evolved globally, Chicago, like many other major hubs, was at risk. And in fact, the second case in the United States was diagnosed in Chicago, and at Northwestern, which is the biggest the hospital system in one of the biggest health systems in the Midwest, and we are situated in the prime location of Chicago, right in the center. So we knew that we're going to get really flooded with these cases. So we needed to prepare, and we did, both on the clinical side, but also on the academic side. We have a very large program project grant led by our medical director of ICU, Dr. Rich Wondering, and as part of the program project, that grant, there are multiple investigators that are passionate about understanding the pathogenesis of pneumonia and how it affects the lungs. So we were able to reconfigure the flow of things into COVID-19 pneumonia. And early on, some of the work we did resulted in changes in our clinical practice. And sometimes these were some simple changes that we found quite impactful. For example, we were the first programs that started performing bronchoscopy in these patients very frequently, like toilet bronchoscopies, sometimes, a couple times a day. And this is when there was a lot of hesitation in doing aerosolizing procedures throughout the globe in these patients. We also started a regional ECMO program in the Midwest for COVID-19 patients, and that allowed us to get a lot of really sick patients with ARDS. And then we simultaneously started a warm autopsy program. And the idea behind that was to obtain tissues in patients who are dying as a result of COVID-19 prior to them going to the regular autopsy, which required a pretty rigorous decontamination process over many days to prevent infections or transmission and so forth. Now, the traditional autopsy program we thought would dramatically alter the tissue quality, reducing our ability to understand the mechanisms of COVID-19. So with this warm autopsy, we would enter the negative pressure rooms in which these patients were being cared for. And then after they expired, we would perform the autopsies in the room and then collect the tissues and take it to our laboratories and perform the the analysis that we wanted to do perform. So one of the this paper came out a little bit later, but in Blue Journal, we actually found that even with simple clinical changes in clinical practice, for example, the bronchoscopy that I mentioned, you can accomplish pretty good outcomes in patients who had severe ARDS. So in fact, in the first phase of the pandemic, our mortality was 19%, and that's remained actually, it's remained less than 15 to 20% ever since. And in patients who didn't have bronchoscopy, their mortality was almost 1.5 to 2-fold higher. And we found that early on, a lot of these patients were just developing respiratory failure because they just had tons of these thick secretions, and this was combined by the fact that the normal respiratory hygiene was reduced in patients because of limited or reluctance of the care team to go and do these kind of suctioning procedures or enter the room and so forth. The other important observation we made early on was, despite doing these quote unquote high risk procedures that generate aerosol, including bronchoscopies, trachs, and what have you, and intubations, we had no transmission from patient to the provider. So attendings and fellows, the house staff, we prospectively monitored these care providers, and in the study that recently came out, we in pretty rigorous follow-up in these providers, we had just one documented serology positive, and that individual ultimately, it turned out that may have been exposed not at work but at home. So these observations allowed us to get more develop more comfort in caring for these patients, but also, these clinical programs like the warm autopsies and the bronchoscopies allowed us to obtain critical material that enhanced our understanding of how COVID biology evolved. Using the prospectively collected bronchoscopy specimens and our laboratory model, we were able to publish this paper in Nature last year. This work was led by our pulmonologist, Dr. Scott Buttinger, and who's the chief of pulmonary medicine, and Dr. Rich Wondering. And this is just an illustration of what we found and what we were proposing. So in this paper, we found that the SARS-CoV-2 virus enters the epithelium through the ACE2 receptors. That was somewhat known, but in an ACE2 receptor independent manner, it can actually infect the tissue-resident alveolar macrophages, which are inherent cells in the lung. These are homeostatic cells. These infected tissue-resident macrophages then ultimately produce certain chemokines and cytokines. They recruit the T lymphocytes. And when we performed the T cell receptor sequencing of these T lymphocytes, they were specific to the SARS-CoV-2. Ultimately, interestingly, these T lymphocytes induced triggered a death pathway in these tissue-resident macrophages, and ultimately led to the death of these homeostatic cells. At the same time, these lymphocytes recruited monocytes into the lungs, which differentiated into what are called monocyte-derived alveolar macrophages. So they're phenotypically indistinguishable from the tissue-resident macrophages. But the interesting thing is these monocyte-derived alveolar macrophages are very pro-inflammatory and pro-fibrotic. And they can produce a lot of these growth factors that result in replication of fibroblasts. And these monocyte-derived alveolar macrophages also have this tendency of cross-talking with the T lymphocytes and recruiting more of these monocytes that ultimately become monocyte-derived alveolar macrophages. And this is what is shown in the figure, the panel 5. So the reason I wanted to explain this is because this finding of crosstalk between monocyte-derived alveolar macrophages and T lymphocytes, and the persistence of this crosstalk over the lifespan of SARS-CoV-2 and beyond when the patients recovered, allowed us to understand why in some patients there was progressive fibrosis, and why in some patients we had this relapse even when they had recovered from SARS-CoV-2. The next study that we did was to then ask, as a result of this crosstalk and this pro-inflammatory growth factors, how is that affecting the fundamental structure of the lungs in patients who have SARS-CoV-2 infection? So we developed a technique which is called tissue. Simply put, it's a technique where we clear the tissue, the human tissue, and allow a light of a certain wavelength to pass through it. And the idea there is to understand the basic framework of the lungs. It's like, sometimes you may have seen, a leaf of a tree. You take away the chlorophyll from it, and you can see the stem and the basic framework of that leaf. It's the same kind of principle, and the idea behind doing that was to ask the question again, study the framework of the lung. And we had grossly made the observation that in some patients the structure was lost, and if the structure is lost, then it's unlikely that these lungs would recover. So this top video shows you how a normal lung looks like using this technique of matrix imaging. So you can see these very delicate network of collagen in a normal healthy lung. It looks a little bit haphazard, but this is how that framework looks like. The next video that's going to come, this is of a COVID lung, and you can see that the basic framework has been lost, and all that's remaining there are these inflammatory cells. Most of them are T lymphocytes and those monocytes. They're cross-talking, but they're destroying the basic framework. And this correlated with some of the histology that we saw early on. You see a lot of pus and just inflammatory milieu. But then if you take these patients 8-10 weeks down the road, the lungs look like it's like an overcooked steak. They're very leathery. There's no architecture left in those lungs. To better understand the mechanisms of this SARS-CoV-2, we then developed a machine learning based approach where we dissected the lungs, isolated individual cells from the lung. We sequenced all of those lungs, and we asked the question, what is different on the transcriptional basis? What is different in these lungs compared to a normal healthy lung, or compared to a lung that has pulmonary fibrosis? And I'm not going to go into too much detail. It's meant to be more of a clinical talk. But basically what we found was the presence of these unique abnormal epithelial cells, which were characterized by the expression of keratin 17. We found the same cells in other disease states, including pulmonary fibrosis, sarcoidosis, even emphysema, and so forth. So basically, end-stage lung disease that had fibrosis had these cells, and they were very prevalent in patients who had COVID-19, severe ARDS and associated with COVID-19 and didn't recover. In immunohistochemistry validation, these are different patients, but we found these pink cells, which are the keratin 17 cells in all of them. But interestingly, as we performed multiple different markers, we found that they were right next to these green cells, which turned out to be fibroblasts. These were collagen 1A1. This is just a lineage of fibroblasts, and they were right next to them. And that led us to the next hypothesis, which was asking the question of whether these keratin 17 cells may not only serve as a biomarker of permanent lung damage from COVID-19, but potentially may be driving the lung fibrosis. So we developed single-cell RNA sequenced data sets in our institute. We also developed the same for the BAL that we were collecting that was published in Nature. And then we also tested this using nuclear sequencing at the single cell level from the COVID and ARDS lungs. And you can see these red cells present in all of the different data sets. One of our peers, and they had also published independently, they had published their single cell data set, and we did a secondary analysis of their findings, and we discovered those cells even in their independent analysis. And then we started to ask the question how these cells may be driving fibrosis. And we found that these cells, which are represented as aberrant epithelial cells, using this Interactome analysis, we found that they were simply put talking to other fibroblasts. And the thickness of these lines and different colors tells you how strongly they're talking to these different cells. And this was most strongly the talk or the interaction was most strongly between these keratin 17 cells and myofibroblasts. And we validated that across the different data sets that I mentioned. In single nuclear set, you see the same pattern, although the crosstalk's a little bit less because you're only doing nuclear sequencing. And then ultimately, this is what we found, that in different data sets, these were the different pathways through which they were kind of interacting with each other. And most notably, PDGF, platelet-derived growth factor, came out. So we are working on this, and we found that the platelet-derived growth factor A interacting with the receptor A is the most potent interaction, and we think that this may drive pulmonary or lung fibrosis in many individuals that develop COVID-19 long-term or in the short term. And interestingly, this pathway seems to exist in other disease states that lead to chronic fibrosis as well. So there are more to come on that. Now, this observation, fits really well with our with the clinical scenario. So if you take all patients who get placed on ECMO, for example, for COVID-19 ARDS, if you take all patients, yes, their survival to discharge may be 60+%, depending on the reports. Some reports show like 20, 15%, some of this may be center variation, but if you look at the ELSO registry or the high volume centers, including like Sinai, it's above 60% in patients who get on ECMO. But and this is what we found as well, if you take all comers up front. But we asked, based on these observations, we asked a slightly different question, which is, how does that probability change over time? So in patient who is on ECMO and then remains on ECMO at 30 days, what is the probability that that patient is going to come off ECMO and survive to discharge? And we found a pretty significant drop in that probability. So in fact, by day 40, so if a patient remained on ECMO at day 40 from COVID-19 ARDS and could not be weaned, their probability of coming off ECMO was 5%. And this correlated very well with the presence of these keratin 17 cells and development of that lung fibrosis. Even patients who, I will just show you the graph on the right side here. So even patients who just focus on the black line that that's present in that. So even in patients who remain on ECMO for more than 30 days and were able to come off ECMO and get discharged, we follow them over time. And if you see at 1 year, their survival is only about 70%. So a number of these patients, when they get discharged, they languish in the rehab centers or in the LTAC and so forth, and they ultimately end up dying. So demonstration of fibrosis in lungs in COVID-19 patients, demonstration of the probability reducing over time, and as I said, at around 30 to 40 days, less than 5%, then allowed us to with conviction say that lung transplant would be a life-saving option in some of these patients. So with that, I want to pivot to the actual lung transplant and share with you some of our observations, having set that groundwork. The indication and the candidacy were the two biggest debates about whether we should be thinking about lung transplant as a treatment option in these patients. And the indication was really based on that question, which I hopefully just answered, which is, does COVID-19 result in permanent damage or can it lead to permanent damage in some patients? And how do we potentially identify those patients? So clearly it was evident to us based on all this work that I just shared with you, that it indeed causes irrecoverable damage in some patients, not all patients, in some patients, and in those patients, lung transplant will be life-saving. The second question still remained, however, which was about the candidacy. And the question was, in these patients who've been on ECMO or ventilator for weeks, they've had numerous complications, they've been immobilized, they're frail, they're deconditioned, can they even go through something as complex as a double lung transplant? That remained to be seen. We didn't have data, but we felt based on our clinical assessment that in carefully selected patients, they should be able to get through the double lung transplant, because the idea here was that these patients that we would select for lung transplant were reasonably healthy before COVID happened. So they were in a normal disease state, they were very active, and you've had an acute duration illness that has made them frail. So if we could just fix the lung part of it, they should recover. Unlike a chronic patient or a patient who has chronic end-stage lung disease, for example, emphysema or COPD, they've been sick for years, and they've had lots of treatments, steroids, antifibrotic. And if that same patient got to develop ARDS and remain sick for 6, 8, 10 weeks, what have you, those patients would not likely be able to survive lung transplant. But these COVID-19 patients are different. That idea led us to apply all the work that we had done. And during the warm autopsy, we had actually we were fortunate because we learned important technical nuances, what the lung looks like, how bad the adhesions are going to be, how we're going to suture all the different anastomoses. And that allowed us to do the first successful double lung transplant in the United States for COVID-19 on June 5th. This is in a lovely 28-year-old Miss Mayra Ramirez. And I'll briefly share with you her story, her medical story, just to help answer that second question pertaining to candidacy. So this is a 28-year-old. She had well-controlled neuromyelitis optica. She was actually on rituximab, but once every 3 to 4 months. It was very well controlled. She had a short duration respiratory illness on day 1. When she came to the hospital, she got intubated, very rapidly progressing into COVID ARDS. She was on ECMO within a week. And then subsequently, she developed many complications, which was not atypical for many of these COVID-19 patients that came. So serration pneumonia within 3 weeks, right heart failure from pulmonary hypertension leading to a congestive hepatitis, acute kidney injury. She was on dialysis. And once she had a spontaneous liver bleed from capsular hematoma, and just because of the severe liver congestion that required emergent laparotomy with over 20 units of blood transfusion. But despite all of that, she became COVID negative by 4 weeks, and but she was sick. These are some of our x-rays. So you can see on day 1, there is this left lower lobe infiltrate that progresses to bilateral. By day 7 and day 11, this is like, almost a whiteout with an effusion on the right side. Day 14 and day 21, same thing. And day 21, you can start to see this cavity developing in the left lower lobe. And that was the serration pneumonia, necrotizing serration pneumonia. But just before transplant, you can see how that whole left lung is full of air, fluid levels with just massive necrosis of the left lung, and the right lung is really not existent. This is just an example of what we see. This is not Mayra, but just to emphasize again what we just talked about. This is a patient who was on ECMO for 9.5, almost 10 months, was transferred to us, and then we are doing a double lung transplant on that patient. So the right lung, this is halfway through the lung transplant. So you can see the right lung, very nice, and is inflating with normal compliance. This is only with a 15 of inspiratory pressure. The left lung is the COVID lung, and we are applying with a separate ventilator a pressure of 70, and you can see it barely moves. So again, by 9-10 months, if the lung looks like this, I really would challenge anybody who would say that there is still a chance of lung recovery in this. The reason I wanted to show this video was to point out that Mayra's lungs look worse. And this is a example of or picture of her lung. So you can see this is her histology. You can see just how leathery and fibrotic these lungs are. And on a longitudinal section, you see there's just no architecture. It's all completely fibrosed. And in fact, she had developed these punched out holes. This was, again, the first explanted lung ever in the United States, but this observation was subsequently shared by many different centers, this formation of these holes, which ultimately turned out to result from the ischemic events that were happening within the lung. And these cavities or the holes, like the Swiss cheese defect, they were harboring a lot of nosocomial infections, and it was impossible to clear those infections just because there was no penetration of antimicrobials. We even tried inhaled antimicrobials in these patients and so forth, but it just never resulted in clearance. And these patients then ultimately died of sepsis and related complications. So we've done a number of transplants, and you can see some examples of the explanted lungs and at various time points in the course. And they have every single transplant that we've done, they've had on histology and gross analysis, no architecture left. This is Myra, though. Despite all those complications that I just listed, she is here. She's on day 10, and I just want to remind you that she's now been immobilized for over 7 weeks, has had all these complications. She's never gotten out of bed, but here she is on day 17 doing bicycling in her home, and then within a month she was discharged. So. Using that, the first case, I wanted to then share with you our experience that we recently published in JAMA. This is the experience of the first 30 consecutive patients. Now we've done over 54 or some, and the results I'm going to show you, they continue to hold true even in our most recent cohort. So this study included all patients with no exception between January 1st, 2020 to November 15, 2021, in both COVID and non-COVID patients. The patients who had COVID-19 all received double lung transplant using central VA ECMO. And now I'm not going to include patients who had long-term lung fibrosis. That's a separate cohort, and we've done some singles on them. They're not included in this cohort. These are strictly severe COVID-19 ARDS patients. Majority of these patients were bridged to transplant using VA ECMO, and importantly, median time from onset of ARDS to transplant was about 100 days. Despite their very complex course, at 90 days, they had 100% survival. And at 1 year, we have a survival close approximately 98%. No recurrence of SARS-CoV-2 or any of those nosocomial pathogens that were infecting the native lung was found. These are some busy tables, but I'm just going to point out one or two things because those are the points I want to make here. So the first thing here was in this table was the performance status. So if you see these patients, the COVID-19 patients had a much lower performance status, which is not of any surprise compared to the non-COVID group during the same study period. The non-COVID group are patients who have chronic lung, chronic lung diseases, like the ILDs or the sarcoids or the COPD, CF, all that. Also, in the COVID-19 cohort, which were the ARDS patients, 56% were bridged to transplant. They were on ECMO prior to this transplant. But in the non-COVID group, only one patient was on ECMO. The lung allocation score, if you look below, was much higher in the COVID-19 group, which is also not of any surprise compared to the non-COVID group. And because of that, their time on the wait list was much shorter than the non-COVID group, only about 11 days as a median. And interestingly, none of the COVID-19 patients had received vaccination prior to the transplant. This is the improvement in performance status before and after. So you can see the black line represents a non-COVID group. So they start higher and they get better over time by the time of discharge. But the COVID-19 group start much lower, but they reach almost the same performance status by the time they're discharged after the transplant. Again, highlighting that in carefully selected patients, they are good candidates. The second table from that paper, just I wanted to highlight a few points. So number one, these patients do require this is a much more difficult operation compared to non-COVID disease states. It takes about 8 to 9 hours compared to about 7. More importantly, the blood transfusion is much increased intraoperatively in these patients. They have very severe adhesions in many patients, not all, but in many patients, and they just tend to bleed a lot. We are trying to figure out why that is. It probably is from the adhesions, but also there is something about giving anticoagulation in patients who have COVID-19. We've just observed that they tend to bleed more. So the same 5,000 heparin would cause much more bleeding in these patients than a non-COVID. Now, I don't have scientific proof for that. It's something that we are working on, but I'm just sharing with you what we've just observed intraoperatively. So the point being here, for COVID-19 patients, if transplant is considered, I think a discussion needs to happen with the blood bank to make sure that they are prepared. In some patients, we've had to use upwards of 20 units. And if it's a rare blood type, it could be a problem for the blood bank. These patients tend to have a much higher PGD rate. So within the first 3 days, a 70% incidence compared to only 20% with the non-COVID patients. And their ICU stays tend to be much longer, and their post-transplant vent use tend to be much longer. But despite that, if you look at the bottom of this table, with a follow-up of over 351 days, we've had 100% survival, which is much better than the non-COVID group of 83% at about 500 days of follow-up. This is just to show you the study cohort, 100% survival with that duration of follow-up compared to the non-COVID group. So this is a proportion of patients who died non-COVID, these results are consistent with the national averages. We are a 4-star program, an SRTR. So our non-COVID group is pretty good. So the reason I mentioned that is the COVID-19 outcome is not just unusually superior because our non-COVID group is inferior. So our non-COVID outcomes are pretty consistent with national averages and so forth. We also looked at, compared this with what the national cohort looks like. So just using an unbiased Kaplan-Meier comparing COVID-19 with all non-COVID patients in the SRTR or after propensity matching them. And we found that the COVID-19 ARDS actually do much better than the non-COVID patients in the national cohort. So this, again, I shared with you just to emphasize that in the candidacy part, the second part of the question is the answer should be yes, they are candidates. And the important part there is that you have to carefully select those patients in order to get those outcomes. This is a international cohort that we had put together, including centers from US, Vienna, Italy, and India early on in the pandemic. After we successfully did the first few transplants, we wanted to make sure we share our experience, and we put together this cohort to then develop some consensus. And all the things that I shared with you were also true in this paper that was published prior to our JAMA paper. But the important thing was consistent with what I just showed you. All these centers experience the same level of fibrosis and lung necrosis as reflected in this panel G here. Is one patient where you see this lung completely fibrosed and in fact developed a necrotic cavity, which is colonized by Aspergillus. Similar to what I just showed you also of 100-day, from onset of ARDS to transplant, in this cohort, we found that in all these transplant centers, the time from onset of mechanical ventilation to transplant was upwards of 70 days. I'm not going to go into detail, but for people who are interested, in that paper in Lancet Respiratory Medicine, we had suggested some general criteria, how we should be approaching these patients, what should be their neurocognitive status, how do we go about checking the COVID-19 and how do we determine irrecoverable lung damage and so forth. So we've used all of this to, incorporate this into our clinical workflow. This is evolving as we, understand more. We certainly perform our research, assays, although we don't like to incorporate that in clinical, when we have these kind of presentations, because those assays are not available to everybody currently. But in principle, what we do is, any patient who has COVID ARDS, we continue to give them the best medical therapy. And we assess, at the first kind of level of transplant discussion happens around 4 to 6 weeks. And this 4 to 6 weeks came from that ECMO graph that I showed you. So if you made a call, by 40 days, their probability of survival is less than 5%, at least that's what we found. And most patients go on ECMO within the first week or 2 weeks. So if you add 40 with, the 1-2 additional week, that's how we got to that 4 to 6 week window. So we don't even have discussion about transplant unless the patient has reached that 5% survival rate. And people can argue maybe we should be having it earlier, but again, lung transplant is a resource constrained treatment, and ultimately, if we can get someone better spontaneously, that should always be the best outcome or the preferred outcome. So we don't even entertain anybody less than 6 weeks unless there was some medical complication complication that could not be managed medically or with ECMO. That is extremely rare. So after 6 weeks, we see, what is the recovery and if there is a sign of lung recovery. If there is any sign of lung recovery, or if we can continue to support these patients in the absence of complications, we continue to defer the transplant. So they go back into the medical management. But if there is absolutely no recovery, if they are starting to develop some complications, then we start to think about transplant. We always look at COVID clearance. So these patients, at our institution, we would not transplant anybody who's even PCR positive. We don't have culture capabilities right now. In the next 3 to 4 months, we will have it. But we just don't want to take that chance. And honestly, I think if someone is PCR positive, I think we haven't given that patient enough time to demonstrate irrecoverable lung injury. And then we look at single organ failure, and we have our criteria and so forth. We have evaluated patients for lung, kidney, lung, liver. There's some on the list and so forth, but that's a separate kind of topic. This work that I've showed just showed you was also validated in the analysis of the SRTR, which was published in New England Journal of Medicine, actually on the same day as our JAMA paper. This is a work from Cedars-Sinai. They just looked at just absolute graft and overall survival in the SRTR. And you can see that by 3 months, they're showing 97% survival, graft survival and patient survival, which is quite remarkable given that these patients are extremely sick and probably some of the sickest transplants that we've transplanted. I think I'm going to skip through this. This was the last topic I thought I'd briefly cover, but essentially we are, trying to address the question of how we should be approaching patients who've had SARS-CoV-2, historic SARS-CoV-2, or have recently recovered from SARS-CoV-2. Millions of people in the United States have been affected, and if we start saying no to those patients, we're just not going to have enough organs. So we've developed a protocol that we use at our center. This was published in the American Journal of Transplant a few months ago, and this is also going to evolve a little bit more. But one of the things that we have used is ex vivo in some patients where we want to understand, and I'll show you a quick video of that, a patient that we transplanted with a recent cleared COVID, but we wanted to make sure that there is no lung injury. So I just want to end by, I'll just summarize a few things. I think the need for lung transplant for COVID-19 will likely persist. And I say that because although the incidence hopefully will go down, I say that because, we continue to see COVID ARDS and we continue to see COVID fibrosis long-term. And this is likely from the first paper that I shared with you in Nature, indicating that many of these patients have this persistent inflammation, which can drive lung fibrosis. The other few points I wanted to make are listed here. They include lung transplant for ARDS in general. It's not something that is absolutely new. It usually is not within the treatment paradigm, but what COVID-19 has really taught us is that you can take an extremely sick cohort of patients, but when you carefully select those patients, you can get them a really good outcomes. So in the United States, every year, it's estimated that over 200,000 people die of severe ARDS. With influenza alone, we have over 60,000 deaths each year. So at Northwestern, we see upwards of 1,000 ARDS patients every year from different causes. And as we did our analysis, this is prior to the pandemic, even with very conservative figures, we found that 8% of those patients would have benefited from lung transplant. So although COVID-19 may dramatically go down, I think that the need for lung transplant for ARDS will likely go up. The explanted tissues are, I think, like a gold mine for understanding lung injury and fibrosis. I shared with you some of our data in the earlier slides, and hopefully that will help us understand how lungs get injured and how they recover. That gives us a really unique opportunity for drug development and so forth, and not just for COVID-19, but for lung injury in general. And then lung bioengineering is an important part of this. And we've successfully used that, as I mentioned to you, in a patient where we took COVID, recently recovered from COVID, and you can see that there is this inflammatory area. So we did, brought these lungs back, and we were able to test them at our center, do some biopsies with histologies, have a pathology confirm that there is no long-term fibrosis, and we were able to transplant them. So I just want to end with that and share with you some pictures from Chicago for anybody who may want to visit some point. New York is a beautiful city, but Chicago is also beautiful when it's nice. And for those of you who may want to contact me or want to read the non-medical side of how this all evolved, we recently published a book which is available on Amazon and so forth. And below is my email. If any questions come up and so forth, I would be more than happy to talk to anybody offline. Thank you so much for the opportunity. It was a pleasure.
It was a great talk, Dr. Bharat. Any questions, anyone?
Oh, that was certainly a very exciting presentation and courageous, basically making new frontiers. But this is an enormous undertaking, and I'm just curious how much it costs and what is the impact on the families of these patients?
Yeah, I mean, that is a, very, very good question. Actually, and this question has been asked. So actually, there is this TV show called ABC Nightline, and, Juju Chang was actually asking the exact same question that you asked. What is the cost of this, and is it really worth it, particularly in the circumstances of the pandemic? But, I've enumerated some of these examples in the book that I wrote, but, for these families, right? I mean, they're desperate. And a number of these patients, unlike the chronic patients with chronic disease, these patients, they've never even thought of dying. They're otherwise healthy. And like Myra, for example, that we transplanted, I share her story with her permission, but she's 28, never thought of dying. And then now she gets COVID, comes to the hospital, not knowing that she would be placed on a ventilator and on ECMO and potentially never wake up. Never had the opportunity to even do things that she may have wanted, I mean, who thinks about dying at 28, right? And her family had never thought that they would, or her mom, like they would lose someone like her. And then think about this, at least during the pandemic, these patients are isolated, families cannot meet them. They don't even have the opportunity to say goodbye. So most patients died like that. They would just die in a dark room, in a negative pressure room, without having any family members next to them. And they all went through this decontamination process. And many days later, when the body even doesn't look like their loved one, they would be returned back to the family. It was a huge emotional ordeal. So these patients and their families were desperate. And I think every single patient that we've transplanted, these families have been greatly appreciated, and all these patients have been able to go home. And the other point I would make is, even if these patients, we know that transplant is not, these lungs don't last forever, and we've actually had to retransplant one of the patients recently, and that's not surprising. So the thing though, the point here that I'm trying to make is, even if they got a median of 10 years out of this, that's better than, you take a cohort of patient that would just die and you take and improve their mortality. That's better than anything that we do in thoracic surgery. I tell you, lung cancer also does not give you that much of an impact. So yes, it's a costly undertaking, but just like a lot of what we do, I think this has been worth it for the family and the patients.
So, Ankit, I have a couple of questions. That was a great talk. And, here in New York, when the pandemic started, as you can understand, most of the operating rooms were closed.
Mm-hmm.
There was nothing happening at most institutions. In fact, we had to go to the Central Park to keep patients and all. I'm sure you have seen that. And I can relate to the bronchoscopies, early bronchoscopies thing. One of our own faculty members, a very renowned faculty member, and who actually had COVID and died of a thick plug in the ET tube. And when he just went asystolic, and we were in a situation to have teams doing CPRs for extended periods of time. ECMO, at least at our institution, not at Mount Sinai, and other institution, was out of question because it was resource utilization rates were so low for us at that time. Having said that, do you think the COVID ARDS, in your opinion, when compared to influenza ARDS or any other ARDS, do they have is it a different phenotype? That's my first question. And the second question is, I'm sure you run the ECMO program there, and for respiratory failure, what was the longest time you waited for recovery on an ECMO patient?
Yeah, great. Thanks, Harish. So to answer your second question, which is the shorter one, the longest we've supported someone is 10 months at our institution. But then we've had, some patient, actually one patient who transferred collective ECMO was about 11 months or so. And they just didn't get better. And we didn't necessarily wait for lung recovery. Beyond a certain point, we knew that it's not going to get better. It was just trying to get that patient ready for transplant. We try to rehab them as much as we can if there is an opportunity, unlike our first patient who was just young and actively dying. So if there's an opportunity, we want to wake them up, we want to get them to a good shape. A lot of these patients are heavily sensitized for PRAs, so we want to try to desensitize them. So it's the collection. And kind of what you alluded to, we are really tight on beds, have always been, including the time of pandemic. So the transfer sometimes took weeks to months to come to Northwestern. Sorry, go ahead.
Go ahead, please.
Yeah, the first question that you answered, I do think that there are some differences between COVID-19 and the regular, the influenza, whether it's directly related to biology or was it because this was a new virus for a population? It's yet to be determined, because the newer strains in the recent cases, we tend to not see the same changes that we saw early on in the pandemic. Is it because the strains are different? Is it because now there is more immunity in the population? It's not clear. I will tell you that unlike the influenza and other types of infections, we don't see, the work that was published in Nature, which suggested that these patients in some patients have ongoing inflammation because of this crosstalk. That does not seem to be true in influenza and other viruses. So the COVID-19 certainly in some patients is a different phenotype, I think.
Right.
Thank
Here
you.
in New York, a lot of us have listed the patients for transplant on ECMO and high flow or on positive pressure. As you know, lung donation rates in our area are very low. And what we have seen is all the patients whom we thought were candidates for transplant and listed either on ECMO, either on vent, either on high flow. Half of them did not survive, rapidly declined. Half of them actually recovered, whom we thought very good candidates for transplant. And we followed them, and the CAT scans and the x-rays were like big bullous changes, either because of positive pressure damage or infection. And they continue to recover. And one of our own faculty's patients, phenomenal recovery after 8 months of ARDS ECMO support at Cornell. All the 3 programs that are here in New York, we all went and saw that patient, and we thought she may not survive. And Columbia and YU, we all went there, but she survived and she is thriving and went to her son's wedding 2 weeks ago.
Yeah.
So that's been our experience, but we were never in a position to really push the agenda of acute disease and transplant because of several other factors than just the intention to transplant. We agree that there are some candidates that would definitely need transplant. That would be the only life-saving intervention.
Yeah. No, I agree with you. Certainly we see those patients. We've also seen those patients. So we've only at Northwestern done about, as I was saying, 54, 55 transplant, but we've treated a few thousand COVID ARDS patients. So it still is a small cohort that you have to identify. So it's not like, you just list everybody. And we clearly see some patients who have recovered after extended duration of time. But I direct your attention to the graph that I showed you. So even at 40 days of ECMO support, the survival to discharge is not 0. It's 5%. So if you take 100 patients, you're going to have 5 patients who are going to have recovery after extended duration of time. But the point of this is, can we use those anecdotes to deny a life-saving procedure to other 95% of those patients who would have benefited and made it? So it's all about, that perspective. So yes, I mean, I agree that there'll be some patients. So once we list the patients for transplant, we continue to keep our eyes open for lung recovery. We don't necessarily commit. If they start to show lung recovery and so forth, we would change the path to bridge to recovery.
So how many recovered of the patients?
Just 2 so far. The ones we've only had 2 patients who were they were outside transfers who were sent to us, and they've actually had 2 patients that recovered. But we, the thing is, we have the advantage of using our biochemical assays and lots of other things that we've developed. So when we list someone for transplant, we are absolutely sure they're, at least based on all the metrics,
Yeah.
But again, I think it's okay. I think it's fine to accept that some patients will recover after. So just like any treatment we do, even in general transplant, I bet, not every CF patient or not every ILD patient will die if you don't transplant them. So it's all about treatment versus control. And I think in this, it makes sense to us.
Ankit, thank you so much for that amazing tour de force. I have a couple of comments and a question. One is that I love how you laid the basic pathophysiology framework before proceeding to this kind of very targeted, obviously, transplant program, the COVID transplant or COVID ARDS. Couple of comments relating to Harish. Obviously, we saw a major brunt of it, and essentially the hospital at its peak had about 700 COVID patients, and let's say about 150 or so in the ICU during the peak between March and May. And then, of course, we had another wavelet and another wavelet, and we did about 20 or so ECMOs for COVID. And we had about 5 people survive, let's say a little bit over 20%. Then one of them later died with, CVA. So we find, of course, that this inflammatory or the thromboinflammatory process does continue, probably due to some of that crosstalk still surviving in these survivors. Okay. And we have done long-term, we had a young guy who we did for 8 weeks or so ECMO. Now, we sent one person to Cleveland Clinic who did undergo a successful transplant, but died about 6 or 7 months later. So I don't even know whether to count that as a successful lung transplant or not. And the other one was waiting in line for the NYU program. And some things happened and he didn't end up getting there. Yeah. My question from your data, it looks like for all practical purposes, these are sicker people. Their duration of surgery is longer, the amount of blood they require is greater, the amount of destruction and the inflammatory milieu is much more profound. However, they still have a better outcome. What explains that?
Yeah, great question. And I think it's all about that patient selection. As I was alluding to, I think so the same outcomes, I don't think will hold true in a patient who has chronic lung disease, who gets the ARDS, gets on the ventilator, and appropriately, in most cases, we exclude them. But these patients, like our first patient, for example, since I shared her story, so she was 28 and she was completely healthy. And she's had a 6-week duration of illness and gotten quite sick. So I think those patients are recoverable after lung transplant, and their body's ability to go through that is much different than a patient who's had chronic disease for decades and then gets sick. I think it's all about that. And I think some programs I've been privileged to hear experience of many centers in the US now and overseas, and not everybody has had the same experience. And when I look at or hear about the patients that have not done well, it's all about the patient selection in these patients.
So much more rigorous patient selection. Yeah. Excellent. And therefore, a more important stewardship of the resources at a time of resource crunch.
Absolutely.
Amazing. Thank you so much.
Is there any data for that? In fact, how many patients died for the lack of transplants? Lack of healthy lungs, basically.
For COVID, you mean?
COVID or any other for that matter, because that's the problem. Resource is so limited, and our population is not cycled mentally, emotionally to donate.
Yeah.
So it's how to then get viable organs and use them, because obviously I call it a gift of life,
Yeah, so the mortality of all, just as of 2 months ago in the US, based on the UNOS and SRTR data, is about 13% in the US for all comers. In the COVID patients who were listed and didn't get transplanted, it's about 28% based on what we know so far. This data may get updated. So the COVID patients are much sicker, they need lungs, and their mortality is much higher. This is not, this has remained somewhat stable over the last several years, and but I do think that there is an opportunity, because less than 15% of all lungs that get offered in the entire country get utilized. So I don't think we're doing a really good job using the lungs that are even available. But also there are other opportunities, and Harish can, I'm sure, can identify. So like we use Hep C lungs now because hepatitis C is treatable. We use DCD lungs, donation after cardiac death. We also have used unique strategies of, things that are not commonly done, like lobar transplants and so forth. So sometimes, you can see lungs where part of the lung may not be usable and the other lobe is usable. So for the right patient, the right one lobe and transplant them, our extended donor criteria. So based on that, at our institution, Northwestern, our mortality has been less than 5%, still not zero. But I do think that there are a lot of opportunities to improve our donor lung utilization.
Absolutely. Because of lack of time, thank you, Ankit, again. It's a great pleasure to see you again, and hopefully our paths will cross in one of the transplant meetings. Congratulations again for your valiant effort in helping the sickest COVID patients and offering them a hope.
Thank you.
We're going to have you back again next year, Ankit, if you would accept the invitation.
It'll be my pleasure.
Thank you. You, by the way, have had one of the highest audiences that we've had at the Critical Care Grand Rounds. Thank you.
My pleasure. Thank you again. It's been a pleasure. Bye-bye.
Thank you.
Bye.
Stay well.
Bye-bye.